So Spanish speakers are less likely to have had access to these things. And by country, look at this. In the US, you have the US English and Spanish speakers. The Spanish speakers in the US are more like the Spanish speakers in Spain and Mexico. So they're less likely to have used anything than the English speakers in the US. So it's not just a country thing, it's also a combination of country and language. But the quit rates are very similar. So at 12 months we're getting very similar rates for English and Spanish speakers, which means that it's not that the Spanish speakers can't use this if they're given access. They can, and they can get very similar results. So that, I think, is how we would reduce disparities. And the same thing is for countries. You can see here at 12 months, US English, Spain and Mexico, you get very, very similar results. Okay, so when I was doing this kind of work, I realized that it is our reliance on consumable interventions that are a major obstacle to reducing health disparities. Medications can only be used one time. Nicotine patch, you put on the patch, costs $3 to $4. At the end of the day, you take it off, and it goes into the garbage can. You can't share it with anybody else. You can't use it yourself. Face-to-face. You know, I'm a therapist. I do cognitive behavioral therapy for depression. Even if I give it away, and for those 10 years we had a depression clinic at San Francisco General, we never charged one patient anything. We did it with trainees, with our pre- and postdoctoral fellows. We charged nobody anything for 10 years. So it wasn't that it wasn't the cost in terms of money, but the cost was in terms of time. If you spend an hour and a half doing a group, at the end of that hour and a half, no other patient can benefit from that hour and a half. Does that make sense? So it's consumable. You use it up. So what we need is interventions that can be used again and again without losing their therapeutic power. That's what we need. And we need interventions that can reach people even if the local healthcare system cannot provide them with the healthcare interventions they need. The depression clinic, which we began in '85, was closed in 2008. Why? The economic downturn. They started cutting budgets. It's closed. Luckily, a new one started, a Healthy San Francisco clinic, which is still doing some of our groups. But it could have ended completely because of the economic downturn. But with a website that's going, that's tested, you can keep the website going with relatively less money. And then finally, it can be shared widely without taking anything away from local populations. My mother is a patient at St. Luke's Hospital in the Mission, for example. They don't use the work we developed at San Francisco General at St. Luke's Hospital, even though it's 10 blocks away. Even at Langley Porter Institute, which is another part of our Department of Psychiatry, they did not use the manuals we developed at San Francisco General for like 15 years. Then they started using them to train residents and so on. But even within the same department, people don't use the things that you develop and you test. But if you do it on the web, you can keep them going with relatively little money so that people can keep on using them, not just at San Francisco General, not just in San Francisco, not just in California, not even just in the US, but literally all over the world. That is amazing to me. Okay, so these are evidence-based internet interventions. Interventions that are empirically tested in randomized controlled trials like you would with a medication or with a psychological treatment, and to change individual behavior to prevent or ameliorate health problems. That's the idea. Okay? So here's an analogy. When you do a medical intervention, you generally use medication. That's the active agent. For a web intervention, it would be information, digital information of a very specialized form. Both can be standardized, so you have 500 milligrams of something, or you have a particular stream on the web. Both can be evaluated using randomized controlled trials. That's what RCT means. And they can be accessed globally if you have the money to buy the meds or the money to get on the web. Cross-cultural, yes, you can do it in theory with medication, and if adapted, linguistically and culturally, you can do it on the web. But the development cost and the per person cost, that's where the big difference lies. Development cost, the average amount of money to get one medication into the market now is $800 million. That's what it costs to get one medication on the average. But on the web, you can do studies, you can create the sites and do randomized trials for hundreds of thousands of dollars, less than $1 million. Big difference. But the per person cost is where the big advantage lies, because the medication, again, the patch, $3, $4 per patch. You need to use it 7 days a week, 10 weeks. So you're talking 7 times 3, let's say 21 times 10, $210, something like that, $250. But on the web, the marginal cost approaches zero. That means that if once I've served 10,000 people with this website, adding one more costs almost nothing, right? There's no really additional cost. And that's where the potential lies. Now, but would people in little towns like Chosica be able to have access to this? I found this website, which really was amazing to me. This is a website in Jauja, Munoz, which is in Jauja, in the Andes of Peru. This is a small town of 2,000 people, and they created a cabina internet, an internet cabin. And with a satellite link, they have access to the web, and they're teaching the people in the town to use computers, to use the web. I thought, if this little town up in the mountains can do this, maybe a place like San Francisco could, you know, I mean, maybe, right? Why couldn't we have a little room like that in the hospital where we would have, let our patients be able to have access to these things, to screen them for major problems and then give them interventions. So imagine then that a patient arrives at a public sector clinic. She's screened for common health problems at its Internet Health Resource Room in her own language. In Lima, it might be in Quechua, because many physicians in Lima can't speak Quechua, right? They speak Spanish only. Okay, results could be printed in English and in her language. In Mexico, it might be Mixteco, for example, right? I mean, you can think of different ways of doing this. It doesn't have to be just English and Spanish here. And then the provider would address the main problem. For example, if the person screens positive for depression, the provider might give her antidepressants and then refer her for CBT, for cognitive behavioral therapy for depression. But let's say the person is Laotian. There is no Laotian provider at San Francisco General that does cognitive behavioral therapy for depression. We could have a Laotian website that provides the cognitive behavioral intervention in Laotian. And then, of course, once it's tested, it could be used anywhere else where there are Laotian-speaking patients, throughout the states, or in Laos itself, right? It's really worldwide. Okay, so when would interventions be used? And I'm not saying that we should take away live providers and give them internet interventions. I'm not saying that. I'm saying internet interventions can be used if no interventions are available. If there are no Spanish-speaking providers at San Francisco General, we should at least have that. While patients are on waiting lists, sometimes we have our patients wait for weeks for treatment. Or during treatment as an adjunct. So if a primary care provider is giving antidepressants, they could also get the psychological intervention that we know works for depression very well and actually reduces relapse compared to pharmacotherapy. After treatment, to prevent relapse or recurrence. For patients who cannot travel to clinics in rural areas, for example, you know, coming for a session, or when a woman is pregnant, or after she's had her baby, it's very hard for her to come to the hospital to get a face-to-face intervention. She could do it on the web. Or for patients who fear stigma is treated. You know, many of our patients say, no estoy loca, no quiero ver un psicólogo. You know, I'm not crazy, I don't want to go see a psychologist, right? So if they could do it at home through the web, that would be help to them. For patients whose providers don't speak their language, and to extend healthcare beyond treatment into prevention. Prevention is something that ought to be done, but we don't have enough resources to really do that, because we're not even giving adequate treatment. So this is a way that we could go beyond treatment into prevention. So what we're doing now is we created this Internet World Health Research Center. We want to fill in this grid. The columns are health problems, smoking, depression, pain, diabetes, obesity, etc. And the rows are languages, English, Spanish. We already are doing that in smoking. We're doing some in depression. One of my colleagues, Janice So, who's a psychologist at UCSF, just got a grant to translate our website to Chinese. So within this academic year, we'll have a Chinese version of our Stop Smoking site. There are 350 million smokers in China. It's just amazing. So we'll be able to reach many more. We have a grant in to do something in Portuguese with a Brazilian colleague, and Jan just put in one to do something in Russian. So this is something that is doable. It really can be done. But you gotta have grids like this to help you. gotta fill this one in and so on. All right. Now, the web is great, but we're going mobile, right? I mean, most of you probably reach the web through mobile devices right now, right? I mean, I know the medical school now is providing all of its first-year students with an iPad. Is that correct? Okay, so you're not going to be using the web on computers. You're going to be using the web on mobile devices. So we have begun developing this Stop Smoking site on the iPhone, and it's being, right now it's being reviewed by iTunes, and hopefully we'll be able to start selling it soon. One of the reasons we're doing this, oh, by the way, it's in Spanish and English. And one of the reasons we're doing this is also to try to generate a revenue stream so we can fund the website, because our research project ended, the grant ended, I had to close down the website, but I didn't want to close down the website. So I asked the donor for some money, she gave me some money, which was really great. And so the website is still up, but we need funding to keep it going. You know, it's not a lot of money, but it's something. So maybe this will help. Okay, so I want to finish up with some major influences, okay? First, I wanted to mention, do people here know Amado Padilla? Okay, Amado Padilla actually ran a Spanish-speaking mental health research center at UCLA, 75 to 89. This book that he co-authored with Rene Ruiz, Latino Mental Health, the review of the literature, was one of the first summaries of Latino mental health. And there were many trainees who have become very well known in the field. I actually was invited by Amado and the group there to the Lake Arrowhead conference, which was the first major conference to try to focus on Latino mental health. Steve Lopez actually was Adrian's dissertation chair. I mean, so you know the thing keeps on being passed on. Amado still is the editor of the Hispanic Journal of Behavioral Sciences. So he was a great kind of model for trying to focus on Latino mental health, which is what we're trying to do with the Latino mental health research program at General. Okay, Peter Lewinson was my dissertation chair at the University of Oregon, and he's the one who really helped me to think about practical methods of treating and preventing depression. And Al Bandura, social learning, social cognitive theory, reciprocal determinism, self-efficacy, human agency, all these things about how the human being can actually have an impact on his or her environment and shape his or her life. Those were these ideas that I have adapted that I call the healthy management of reality for working with low-income patients at the hospital, where we need to actually shape our day-to-day reality to be able to cope with things like depression and so on. And also this idea of cutting out the middle person, go directly to those in need. The idea of creating self-efficacy to deal with smoking, with depression, other things. And then I want to end by thanking my mother, Clara Luz Valdivia de Munoz. This is what she told me in Chosica when we were about to leave. In Spanish, of course, but I figured some of you might not know Spanish, so I translated it. She sat me down when we were about to leave and said to me, your father finished primary school, I finished high school. We want our children to go to the university. We cannot afford to send you to the university here, so we're going to the US, where there are many educational opportunities. Of course, neither she nor I had any idea that one of them would be Stanford University. It turned out to be that way. And then she said, when you finish your education, we will come back to Peru so you can share what you've learned with the people here. Now, like many of our ancestors or ourselves or our parents or whoever the immigrants were who came here, you know, we have not returned to Peru to live. But through the web now, actually, I have a lot of people from Peru being able to use the knowledge I gathered at places like Stanford. And so, thank you, Mami, for having set this as my mission.